Good evening, all. I hope you can see me and you can hear me. I welcome you to the 13th episode of the BOFAS Master Technique series. And tonight's topic is on Cavovarus deformity and the surgical management, which in my opinion is very interesting but challenging subject. And we are privileged to
Maneesh, you've just muted yourself.
Can you hear me?
We can now, yes.
Yeah. So the first speaker, Heath Taylor, he's going to take us through his surgical decision-making algorithm, etc., as per the how to proceed with the surgical treatment. And then our second speaker, Karan Malhotra, he's going to talk about the surgical principles and operations and surgical techniques in detail. And then we'll have about 15 minutes, 20 minutes discussion time where you can pose the questions on the chat or message, and then we'll pick up the appropriate questions and present it to the speakers. So without further delay, I would like to invite our first speaker, Heath Taylor, who is a consultant orthopedic foot and ankle surgeon in Bournemouth and Poole since 2004. Is very much interested in teaching and has been awarded Trainer of the Year Award by Wessex Deanery. He has been a member of the BOFAS Council for 7 years, and he was our president BOFAS in 2019. So I'm looking forward to listen to Heath about his take on Cavovarus deformity assessment and his algorithm. Over to you, Heath.
Thanks, Maneesh. So I'll just get everything going. So hopefully you're hearing me and seeing my slides. If not, feel free to interrupt. So I'm going to go through the decision-making process, which I think for cavus foot and neurological foot, and the terms are used interchangeably, I think is the bit that I found hardest to get my head around. I think actually learning how to do the operations, we can all learn how to do an osteotomy or a fusion. It's knowing which ones to do and when to do it, I think, is very difficult. And Norton Dunn is one of the founding fathers of orthopedic foot and ankle surgery in the UK, and paper in 1922. And there's a really good quote. It says, "In no other branch of surgery is the patient in a better position to judge of the practical success or failure resulting from any operative procedure." And that applies to everything that we do. But it applies particularly, I think, to cavus foot and neurological foot surgery. This is Vitruvian Man, Leonardo da Vinci. And there's a sort of, is this art or is this science? And of course, everything we do is supposed to be very science and evidence-based. And you'll hear much more science from Karan than I think you'll hear from me. And I think definitely in my practice, I think the decision-making in complex deformity surgery and neurological foot deformity surgery particularly, I think is as much an art as it is a science. So I think it meets both criteria. And of course, when we're deciding what procedures to do, we want a classification like this. This is a sort of simplified, I guess, Johnson and Strom simplified version of post dysfunction. I know there's a new flat foot correction, but this is just relevant to demonstrate the point. And this is really nice because if you have stage 1, you use orthotics or a debridement, and stage 2, you do a FDL and a calcaneal osteotomy, and a 3, you do a triple, and a 4, you do a patellar fusion or a triple with an ankle replacement. And, variations of that. But the classification really guides you as to what procedures you're going to decide to do. And so you have a sort of set menu. It's really easy. You have a starter and a main course and a dessert, and there's not much choice as to what to do. And the problem with cavus foot deformity and neurological foot deformity is that you are much more a la carte. And I don't claim the credit for thinking of this, but I think it's a really nice way of thinking about it. And we have all these different options of starters and pasta and pizza and main courses and bread and side dishes. And do you want a steak as well with it? And then some signature dishes, which are the kind of the main things. And so how on earth do you decide when you're faced with this, with one of these sort of complex cavus neurological feet, what you're going to do? And so what I'm going to try and do is give you some sort of logical way of trying to break it down to make it more reproducible. And all of these are neurological feet. The top left one is clearly a very flat foot, but it's still a neurological foot. And the others are all cavus foot. And I don't know how you make a useful classification. Certainly ignore the top left one, the flat foot, but the other 5 are all cavus feet or Cavovarus feet. How you make a classification that all of these fit into that tells you what procedures you should do. And so I'm going to try and put some logic to that. And here's 2 of my patients. You'll get used to seeing this corridor. It's outside my clinic. And these are 2 patients, both with neurological feet, one with clearly very neurological, the younger lady on the left in the tartan pajamas, and the older lady with a very flat foot, but again, a very neurological foot. And so how do we decide what to do? And we'll come back to both of these patients in a while. So what to do? So I'm fairly sort of simplistic in the way I think about things. So as with a lot of things in orthopedics, start proximally and work distally. And I'm going to start at the hind foot, but it doesn't exclude starting at the back and the hip and the knee. And I make no excuses for saying that, don't miss more proximal deformity. So I'm going to go through the sort of a la carte, what's my menu of choices that I have. And this is probably most of the things that I would consider useful when doing hindfoot, when I'm thinking of what hindfoot procedures will I use, whether it's things around the Achilles, calf release, osteotomies, fusions, double, triple fusions, peroneal tendon surgery. So that's all the hindfoot stuff. I'm being slightly sort of using artistic license to differentiate between hind and midfoot. I'm not saying there's a strict border. But then in the midfoot, so what are we going to do in the midfoot? So tib post transfers and split tibant transfers, again, osteotomies and fusions and soft tissue releases and tendon transfers. These are all options for you. And then in the forefoot, so toe deformity, we can correct toes, amputate toes, Jones procedures, do osteotomies in the forefoot, soft tissue balancing. So we've got all these options. I've no doubt you can all think of more things that could be on that list, and that's absolutely fine. So what investigations do I do? Do investigations help us? I think by far the most useful tools for deciding what procedures to do in neurological foot deformity is a detailed history and clinical examination. I think the investigations are a long way in third place when deciding what you're going to do. However, we do them. Clearly, we do plain X-rays. This is a really nice X-ray of somebody with a Cavovarus foot, and I've got a really good imaging department. When I ask them for a lateral weight bearing of the foot, this is what they do, and this is their lateral weight bearing of the foot. And look at the ankle is an AP, and yet their foot is a lateral, and it shows how much of a rotational deformity these Cavovarus feet can have. You can see there's a few little bits of wire from many years ago. Some sort of tendon fiddling procedure was done. I'll use CT scan and MRI scan as well, particularly if we want to know if things are degenerative. If you want to know if joints are degenerate or think about coalitions or abnormal anatomy, I think it's really useful to have CT particularly, but sometimes MRI scan as well. So let's go through a few cases. So this is that lady with a very neurological looking, very flat foot. And she came, and her symptom, she's walked around on this for years. She's got polio and has lived with her polio perfectly well. But her symptom is midfoot pain. That's what she came in with. She didn't come in saying, I've got a funny shaped foot. She struggled to get shoes on and all the things you can imagine. And this is her walking up and down in my corridor. And you can see her left foot's normal, and her right foot, she's got this very planar valgus, abducted, valgus heel. You can see a scar from previous surgery many years ago. And so how on earth do you sort of unpick a foot like this and try and decide what procedures are you going to do to try and give her the function that she wants and needs? So here's her x-rays, here's the weight bearing x-ray. So you can see why she's got midfoot pain. She's got midfoot arthritis, and that's pretty obvious. She's got quite a severe hallux valgus as well. That wasn't symptomatic for her, but it was her midfoot arthritis was a problem. And you can see her walking, despite this crazy deformity. She's a really fit, active lady, lives on her own, does all her own shopping. And that's her weight bearing lateral x-ray. You can see this stuff been done around the ankle before, probably some sort of ankle subtalar fusion. I'm not entirely sure what. Very, very flat foot. So what to do? Well, she had a valgus hindfoot. I think straightening her heel is pretty straightforward. With a calcaneal osteotomy is going to give her a much better position to walk from. And then what about her midfoot? We'll come back and look at the x-ray. So she's got this severe midfoot osteoarthritis. Well, we can deal with that by fusing her tarsometatarsal joints. But at the same time, if we do a corrective midfoot fusion, we can correct that. So I did a corrective midfoot fusion with a medial closing wedge, and I just did an en-bloc resection, being careful to protect all the soft tissues. And then what about in the forefoot? Well, she's got that sort of severe fixed hallux valgus. I don't think any of us are going to try and fix that with a scarf or a chevron or a mica or whatever your preferred hallux valgus option. And I think for me, a fusion is a good option. So you look at a hallux valgus, I think fusing that is going to give her a really nice correction. And so that's what I opted for. And that's what I did. Don't worry about the form of fixation. I use different things now, but it doesn't matter, plates, staples, screws, as long as you get the deformity right and get the bone surfaces together. So nice bony correction. The midfoot fused really well, big bony surface area. She came back to have a left hallux valgus. So this was her about a year down the line. Remember, it was the right foot. She's got a nice straight heel. She's still got a short leg. It's clearly not perfect gait, but much, much better. She can get her shoes on and she's really happy. So that's how that sort of a la carte approach can allow you to put together a set of operations for this lady that will help her. Here's the younger lady that we saw. So she's at university. So she's got Charcot-Marie-Tooth disease. And her main problem was pivoting on her right foot. She was very, very unstable as she turned. She was trying hard not to use a walker. She was still trying to use sticks because she's young, and there was a sort of psychological element to her using a walking frame, which she really struggled to get her head round. But she was stumbling over, particularly when she was turning around, even furniture walking, and she felt very unstable. So you look at her feet, she's a bit Cavovarus. It's not the worst in the world. For a CMT, we see them much more severe than that. Her deformity was really correctable. So this is me. You can see pushing her heel out into valgus. Valgus corrected easily. And look how much residual forefoot pronation she's got, or first ray plantar flexion, if you want to call it that. And so we've got to deal with all of these deformities. And she had this very unstable, very mobile hindfoot, which is unusual in a Cavovarus foot. Of course, they're usually quite a stiff foot. But you can see how I was able to bring the heel from valgus right round into varus. And we screened this. It's all happening almost all at the subtalar joint. So there was, with that heel right there in almost extreme varus, the ankle joint was almost perfectly congruent. So this is a severe subtalar instability, I'm sure compounded by absent peroneal tendon function. So what to do? So we've got to think about what to do. Well, she was in a little bit of equinus. We know that patients with neurological deformity don't like equinus. It's very difficult to walk in equinus. I'll come back to that. But a single fusion, a subtalar fusion, is going to solve her problem with that subtalar instability. It allows you to put the heel into a little bit of valgus and will solve that problem of subtalar instability. And at the same time, she was a little bit unstable in her ankle, so I did a brostrum as well. I'm not even convinced it was necessary, but we were there and I just wanted her to be stable. Then in the midfoot, she had a foot drop. It's very energy inefficient to walk with a foot drop when you're weak anyway, so a tib post transfer will help that. I did a plantar fascial release. I don't always do that. It just felt tight. And because she was young, and if we believe that the relative overactivity of peroneus longus causes this progressive deformity, so I did a peroneal tenodesis in her lateral hindfoot. And in the forefoot, I dorsiflexed her first ray. I put that in forefoot, so a dorsiflexion osteotomy at the base of the first metatarsal. So this is her about 6 months post-op. She's still really unsteady, but you look at her right foot now, she's much more stable. Her hindfoot's not collapsing into varus, and she's able to pivot and stand. She's really happy with it. It's interesting. Her left foot hasn't gone as much. I suspect she'll be back at some point. She's determined to stay on her feet at least to finish university. So she was really happy with that result. Another good example of a Cavovarus foot. That's such an obviously tight Achilles. If you look at the view from the back, you can see it. How tight the Achilles is with the heel in varus, and the heel doesn't even touch the floor. This is him trying to put his heel down on the floor. This is that x-ray you saw earlier on. So you can see how much rotation there is. As I say, this is my really good radiology department taking an AP of the ankle and a lateral of the foot. And it's extraordinary, a couple of x-rays. So what to do? Our easy decision here. We're going to lengthen the Achilles. And we're going to do a triple fusion. This is a very stiff foot with a significant rotational component at the triple complex. So triple, the decision making is easy. This is quite a difficult triple to do if you haven't done many, but for him worked very well. And then he had quite a significant residual first ray plantar flexion. So I opted to do a plantar flexion lapidus rather than just a dorsiflexion osteotomy. It brings the apex of correction a little bit more proximally, and I think it just gives a nicer looking foot. And this is a really nice post-op x-ray, partly because of the crazy metalwork, but also this is that same patient. You can see the bits of wire everywhere. So we've now got an AP of the ankle and an AP of the foot, and a lateral of the ankle and a lateral of the foot. It was a really big rotational correction through the triple complex. And this is him post-op. Foot's now flat on the floor. Still a little bit of swelling to settle down, but wound's healed nicely. This is him walking. Stiff foot, but it was stiff before. He's really happy. His foot progression is much better. And he's got a really nice correction. Another example. Again, Charcot-Marie tooth. Very little Cavovarus. She's all foot drop. Well, she's foot drop and equinus. So look how much equinus she's got. And she's back kneeing and tilting her pelvis as a result of her equinus. And she finds this, she's tripping over all the time, keeps falling over. And of course, she's weak proximally as well because of her neuropathy. So what to do? Again, I think easy decision. Achilles release to get that ankle dorsiflexing beyond neutral. And a tib post transfer. I didn't think she needed any bony correction at all. So, CMT, but with no bony correction. I quite like a split tib post transfer. I think Karen's going to talk a little bit about tendon transfers more than I will. But you can see I do a classic harvest distally, pull it up proximally, make a big hole in the interosseous membrane, and then pull it through. You see the tendon comes through. You can do it as a single strand and just pull it through and stick it into the top of the navicular or one of the cuneiforms. I quite like a split transfer, pulls through nicely through a really big hole in the interosseous membrane, and then you can split it, get a nice balance. This guy's brilliant. So he came into my clinic. This was like my sort of FRCS Orth exam. This guy's 71, fit and healthy, worked all his life, never had a diagnosis. Other members of his family have been told they've got funny feet, but he still plays golf. This is his feet. I mean, it looks like a picture from Apley's Orthopedics. Champagne bottle legs, severe Cavovarus and clawed toes, hindfoot varus, you can see. Those classic x-rays that we've talked about. And this is him walking around. Look at his hands as well. He's got that classic CMT posturing. And he's walking unsteady with his Cavovarus feet and just starting to struggle now as he's getting a little bit older and getting a little bit weaker, but never had a diagnosis. So with these sort of patients, balance is really important. Don't just do bony corrections. Always think about soft tissues as well. So I think, again, decision for him, easy. Achilles release, you could see how tight his Achilles were. Triple fusion, I think, again, is an easy decision to correct him. But we've got to correct him. So this was his weight-bearing x-ray. Look how much his medial structures, the tib post and the spring ligament and those medial soft tissues at the tenonavicular joint are going to be really tight. So you're going to release them anyway. Well, if you're going to release them, why not use the release and do a tib post transfer? So I did a tib post transfer as well as part of my medial release. It'll help his foot drop. And I haven't got his, I don't think I got a video of him walking afterwards. I must get that. I must get him to do that. So before I finish, a few pearls, things I've learned down the way, things I've learned the hard way. Don't leave patients in equinus for a number of reasons. If you leave the hindfoot in equinus, your deformity will recur because the patients will try to push the heel back over into varus or valgus, varus for this purposes of this talk, because the Achilles is tight. You must release the Achilles if they're in equinus. It's also exhausting to walk in equinus because you have to climb over your foot. If you think about trying to walk in equinus, it's really hard. And when you've already got neuropathy, so don't leave them in equinus. And don't forget to treat foot drop. So that guy with the CMT, the golfer, so he didn't come in complaining of a foot drop at all. But I think, you're there anyway. To do a tib post transfer takes an extra 10 or 15 minutes. They don't even know why they like it, but they like it because they don't have to lift the foot up so high to walk. And it goes with the Achilles release. So you can't do a tib post transfer if they're still in equinus. So the two go together very nicely. The other thing that comes up a lot, and Karen's going to talk about this a bit more, I think, is when to fuse and when to do an osteotomy. And I think there's definite art, not science to this. I've definitely regretted doing only an osteotomy. I think if you've got hindfoot varus and you do a Dwyer or a modified Dwyer calcaneal osteotomy, even if you take a big wedge and you shift it a long way, there's only so much correction you can get. And I think if you've got someone with a stiff hindfoot and a significant varus, I think they're probably better to have a fusion, because you can take bone out, you can release, you can get that heel out of varus. But an osteotomy is a good option. But I don't think I've ever regretted opting for a corrective fusion. I've definitely regretted not doing it and doing an osteotomy, and then come back to clinic and you look and you think, oh, it's still a bit varus. So what are we looking for? This is the basic principle. So we're looking for a painless, balanced, plantar grade, not infected. So think about your incisions. They need to be able to feel it. They want to get a shoe on. And it's not cosmetic surgery, but it kind of is. If it looks nice and it looks like a foot, the chances are they'll get a good result. And I come back to what Norton Dunn said. So I think this is really functional surgery, and I think the patients will tell you how successful you are. Thank you very much.
Sure, there will be questions which we'll discuss in the Q&A session. So our next speaker now, I would like to invite Karan Malhotra. So Karan is a very dynamic young surgeon, consultant orthopedic surgeon at Stanmore. I'm sure most of you know him. He's also an honorary associate professor at University College London. He's a member of the council and chair, and he's the director of the Media and Communication Committee at BOFAS. He's very active in research and education and has a number of publications. And Cavovarus foot is actually one of his forte. He loves this topic, and he's going to share his experience with us. Karan.
Right. No, thank you very much for that introduction, Maneesh, and thank you, Heath, for a good talk. I think you've covered a lot of stuff that I was going to say, but it's worth reinforcing. So I'm going to talk about how I correct a neurological Cavovarus foot, and most of what you'll see is going to be things like CMT. Heath said that I'm going to talk a lot about literature, but I just need to warn you that there isn't that much literature out there. So I'm not going to have slides full of literature. Because most of it's based on consensus statements and personal opinion. Just as Heath gave his opinion, I'm going to give you my opinion based on my experience and the literature that's there. But I want to start by presenting what you might think when you start addressing a Cavovarus foot. Sometimes you see a patient and you think, you know what, I'm a great surgeon. I can make this perfect. I'm going to absolutely sort this patient out. They're going to have a perfect looking foot. That's it. And you may even achieve that, and you'll be on cloud nine, you'll be celebrating, but the foot can't take it because it's never been normal, and it all ends in tears. And so what you need to remember is that when your baseline is really poor and you're starting from a really poor expectation, actually all you really need to be happy is to have something stable which protects you and lets you get on with your life. And you have to remember that when you intervene surgically is just as important as what you do surgically, because especially with neurological feet, patients live their entire lives with this problem. And they have lives, things progress, they have to go to university, then they get married, and they have children, and lots of things happen. So you have to be able to guide them. You also have to consider that deformities progress with time, and what's flexible now may become rigid and develop arthritis later. And if it's rigid and it's arthritic, then the complexity of your reconstruction increases. But really, when patients come to me, I sometimes say, what is the tipping point? And I like to think of it like a traffic light system. So if you start on the left, green light. So over here, the weight-bearing portion, so the weight-bearing of the body weight goes through the center of the ankle. And if that then comes out through the heel or close to it, then that patient is relatively stable and they've got time. They don't really need an operation right now, most likely. If you look here, yellow, over here, they've started to tilt and their weight-bearing axis is starting to go to the lateral side of the calcaneus. If they're correctable with insoles, then they're not, and they can look like a green foot with insoles, then they're probably fine. If not, then you want to think about doing something. The next one, which I've labeled blue, looks like the yellow one, but the difference here is that they're an equinus. And so they have less stability, and when they walk, they're more likely to tip over. So that's actually a more urgent situation. Over here, you can see in red, this is probably a bit too late already. And that's when the weight bearing is already past the heel. And this is a bit like the leaning tower of Pisa. Once it's gone this far, it's going to just keep going and rapidly. So you want to intervene soon. Otherwise, you'll get to this stage, the white one, where you really should never get to in the start. So with that in mind, what are my surgical strategies for Cavovarus foot? Well, it echoes what Heath said. I think the first thing we want to know is what are we trying to achieve? What we're trying to do is to put the hind foot underneath the body, get the foot flat to the floor, restore their biomechanical tripod, and then balance the muscles. And if you do that, you achieve what I've got here in the left to here in the right 6 months later. It's all about getting a basic structure that will keep the patient happy, not a cosmetically perfect foot. So, how do you achieve this? Well, you have to assess each aspect and plan to treat it accordingly. You need to work out which soft tissues need releasing, which ones need transferring, and although Heath's talked a lot about lengthening the Achilles and treating the equinus, not all patients have problems of equinus at the ankle. And you need to be careful not to over-lengthen the Achilles. You need to work out which bones need shifting and which ligaments you need to repair, if any. A lot of this, like Heath said, is actually done through clinical examination with imaging as a supplement. I'm going to come back to these images here, but just to highlight it, if you see here, this looks like the patient's in equinus, but actually the equinus is happening at the midfoot rather than the ankle. Fuse or preserve, again, Heath touched on this, and they're proponents of both. I tend to do a flexible one when possible and reserve my rigid fusions for rigid ones or who have arthritis. Either way, they need tendon transfers, and there's some evidence to suggest that if you can do a flexible correction, then they do better with it, particularly the younger patient. But it does depend. The next important thing is the order in which you do things. And part 1 and 2 sort of come together, but you need to prepare all tendon transfers, release all soft tissues, and then correct the bony anatomy in a stepwise fashion, exactly like Heath said, hindfoot, then the midfoot, then the forefoot. And then at the end, you fix and tension tendon transfer. But the key thing here is that this is not just a linear thing, because in order to correct the bony anatomy, especially of the midfoot and forefoot, you have to imagine what your tendon transfer tension is going to be like and what the foot's going to look like, and then correct that. So you do need a bit of experience to do this. But what I mostly do for a Cavovarus foot, if it's flexible, I mostly do an Achilles lengthening or strayer if it's needed. It's not always needed. Lateralizing calcaneal osteotomy, again, if it's needed. And if it's a fixed deformity, I do fusions, as Heath said, either a triple fusion or an ankle fusion or a DTC fusion. I then go on to the midfoot and forefoot with balancing osteotomies, use the hallux IP joint, and I don't often do the claw toes at the same time because there's only so much surgery a foot will take. And finally, I do the tendon transfer, which is often a tibialis posterior tendon transfer, and it can be either to bone or to tendons, and I'll talk about those later. So let's run through all of that quickly. So the soft tissue releases. The Achilles release, with a percutaneous release such as a hook, you can get up to 10 degrees, and often that's more than enough for what you need. Because as Heath said, the heel's just a bit tilted, the Achilles is just a little bit short, and you just need that hook to unlock the Achilles a bit. I do 3 incisions, 3 to 5 centimeters apart, 2 on the medial side. Sometimes you actually just need a strayer, especially in the younger patients who have come early. I reserve an open release for someone who's got true ankle equinus and something like this. So this patient's actually not CMT, they're HSP. But over here, they've got about 35 degrees of equinus. And the formula that you can use is 1 centimeter of lengthening of the Achilles gives you roughly about 5 degrees of equinus correction. And then you want to overlap by about 3 centimeters at least. So to correct a 35-degree equinus, you need about a 10 centimeter Z. My tips for this are that if you go on the medial side or paramedial, that's a little bit nicer for wounds. And you need to keep the end straight. Because if you keep the end curved, which is tempting, once you actually get that equinus up and the foot comes up, that little curve, which is just a harmless little curve, becomes horizontal and then gapes. Whereas if you end it straight, it then actually closes together nicely. Again, I do my medial incision superiorly to go away from the sural nerve, and I do my step of the Z distally laterally to avoid the neurovascular bundle. I leave about 3 centimeters. Other essential releases, I mean, sometimes you need to do a posterior capsule release, but I think the tibialis posterior and the spring ligament are key parts of my releases. The tib post I'm going to harvest anyway. Nowadays, I tend to do it through a small incision, and you can see the tibialis posterior on the left. and I've resected it. And then you can see right under the tib post is a spring ligament, which you can see my forceps pointing to. The spring ligament in Cavovarus foot is your enemy. I always cut it. If they've got severe Cavovarus, I take a wedge out of it. They're never going to get a flat foot. Their bony anatomy is just different. So that's absolutely not a problem. Plantar fascia releases, that's not a usual part of my practice. I only very rarely do it. I don't think it necessarily adds to the stability. And when I do the claw toes, it reduces the tension anyway. Often if I'm faced with someone who needs a plantar fascia release, I'm often going to do a wedge tarsectomy or something with them anyway. And I detension the plantar fascia through there, so I don't defunction the plantar fascia. There are different philosophies, however, and it goes back to what you're trying to achieve, a cosmetically perfect foot or a functional stable foot. But I would occasionally do a plantar fascia release, but not usually. When not to do an Achilles release, so again, this comes back to this situation over here. So you have to look for the center of rotation of angulation or the core of the deformity and make sure that if you're doing a release, you're not over dorsiflexing the ankle to make up for midfoot equinus. Over here, if you see that there is actually not an equinus deformity and the calcaneal pitch is fine. And what this patient really needs to get a perfect foot is a wedge tarsectomy. But that's a bit much. And actually, I've created a slightly zigzag foot with a dorsiflexion osteotomy, which is balanced and fine. On that note, we'll go on to the osteotomies. So if we're going to correct the bony anatomy, what do I do in the hind foot? Well, it's a lateralizing calcaneal osteotomy because that helps to get the bone under the body. You can do this through a multitude of approaches. You can even do it MAS, although it's harder. I tend to use an extended lateral approach because it's versatile, and you can do a peroneus longus to brevis transfer through the same thing if you need to. You need to release the soft tissues from the medial side. So I often put a laminar spreader in after completing the osteotomy, open the gap up, take a little osteotome, go out to the medial side, and really separate the soft tissues on the far side to allow a good shift. I always take a wedge because there has been a recent paper which suggests that there's abnormalities in the bony shape itself, and the radius of curvature is actually abnormal. So in essence, in a neurological foot, the shape of the calcaneus is like a banana. And if you do an osteotomy on a banana, as we all know, it gives a good shift, but it doesn't make it straight. But if you do a wedge and a shift, then it creates a straight structure, which is better biomechanically for these patients. So this is what I do. I do lateral calcaneal osteotomy. I tend to fix it with headless screws because I spend too much time taking out headed screws, but it really doesn't matter how you fix these. So what have we achieved so far? Well, we've got a heel, which is underneath the body, a hind foot, which is flat to the floor, and by releasing the tib post and the spring ligament, we have hopefully reduced the talonavicular joint, which is absolutely key, which I'll come to in a bit. So we've prepared the tendon transfers, released soft tissues, corrected the hind foot. Now we need to go on to the midfoot and the forefoot. So this is about balancing the residual forefoot deformities. The aims here are to correct any residual plantaris or cavus, any pronation or supination, and any adduction. To do that, as I alluded to before, you need to put the foot where you think it's going to be once you've tensioned all your tendon transfers, and then see what you think still needs doing. Most often, you end up doing a first metatarsal dorsiflexion osteotomy. But some patients will need multiple osteotomies, and some patients will need a wedge tarsectomy. But how do you know which one? As Heath said, there's no good Johnson & Strong classification system for this. We've looked. I do a lot of these, and if I'm faced with a foot like this, I'll struggle to know, especially if they're not flexible enough for me to decide preoperatively. So we asked ourselves a few years ago, can you predict what the forefoot deformity is going to look like? And we've done 4 papers on this now. And in essence, what the 4 papers show is that most of the deformity is actually a rotational deformity, about 23 degrees at the talonavicular joint. And what we did is put this into a computer and simulated correction in Cavovarus feet around the talonavicular joint to what we would achieve intraoperatively. Then saw what deformities were left and classified them. So this paper has just been published last month, or 2 months ago now. So we found that 60% of cases are what we term type 1 foot. And that's what you commonly see, where only the first ray is relatively plantarflexed after you've reduced the rest of the foot. But that means that 40% of patients actually have something else rather than what your standard technique might be. And 20% have what we call a type 2, where not only is the first ray relatively plantarflexed, but so is the second, possibly the third. And 10% have a type 3, where they actually have true adduction. Most adduction is actually plantarflexion and rotation in disguise, but some patients have true adduction, And about 10% have type 0, where actually they're balanced and they don't actually have a forefoot deformity at all. So instead of just going with the flow and doing a dorsiflexion osteotomy each time, we think about how we manage each individually. So type 1, just the first ray is plantar flex. These are easily treated with the dorsiflexion osteotomies, which is what we do as standard. And I tend to do a vertical osteotomy because it's more powerful and you can do it through a smaller incision. And I tend to use a medial plate. You can use a dorsal plate. But if they've got a type 2, and you can see here, this is an example of a type 2. And when you correct the foot at the talonavicular joint, you see all the toes are sloped. And you can see over here that multiple toes are sloped. Over here, they need multiple dorsiflexion osteotomies because if you bring the first up to the second, they're still too low. And if you bring the first up to the rest of the foot, the second is too low. You can do a first metatarsal dorsiflexion osteotomy and BRT osteotomies, but I often end up doing multiple TMT joint fusions because I think they have a more powerful deformity and I need to fine-tune things often. And it's a bit closer to the cora. But it doesn't matter. But these patients often have a fused stiff TMT joints anyway. The type 3 is the challenging type, particularly if you're unprepared, because they're often multiplanar with adduction, rotation, and plantar flexion. And these need a more proximal correction which derotates, and this is done by a wedge tarsectomy. Or you can do a Chopard fusion or a triple fusion. But if you're trying to preserve joints, a wedge tarsectomy is the way forward. But the problem is, even if you do a lot of these, if you're unprepared and you come across it and you suddenly realize you have to do wedge tarsectomy, that's a bad day. So wedge tarsectomy is difficult. You got to use K-wires to guide you. You need to really work out how to do it in multiple planes. But fortunately, there is the option, if you're prepared, of using patient-specific instrumentation or a guide. And I tend to use a guide if the deformity is in more than one plane or it includes rotation. I also use a guide if I'm trying to save joints. And if you're starting off, it's something which I would encourage. Here's an example of using a guide. I have a patient who's got a equine or a cavus deformity of 37 degrees, adduction of 49 degrees, and a bit of rotation. That's obviously quite difficult to address, but a guide can tell us how much bone we can take while still leaving enough to fix, and then simulate correction where you don't correct all the cavus, but you've got 20 degrees, which is still better, but you do correct all the adduction and you correct most of the rotation. What does that look like in real life? Well, we put a guide on the side, we saw wedge your bone, and then literally we just close it in one fell swoop and fix it, and it actually works really, really well. What about a type 0? Well, a type 0 has no deformity, so you don't really have to do anything. You can finish the operation there. Talk briefly about fusions. Heath mentioned triple fusions. There is a type of triple fusion modification called the Lambrinudi. So if they have equinus, but the equinus is not just at the ankle and actually occurs within the talus itself or the talonavicular joint, you can then take your saw blade and saw the bottom of the talus off, including the inferior head, parallel to the floor, bring the rest of the foot up and fuse it. And that is, this is the same patient before and after. It brings the equinus up nicely without you actually having to do much to the Achilles. So, if they've got deformity at the ankle and the subtalar joint, then I often do a TTC fusion and a cavus foot correction. And this deformity, although it looked severe, actually had a simple forefoot deformity. It just needed a hindfoot fusion. My tips for fusion is that, remember, the foot is going to be stiff and the bone shape is abnormal. So you have to take out wedges. Don't be shy. I prioritize reduction at the talonavicular joint first because that is what you're going to build the forefoot around. And after you reduce the talonavicular joint, you can try and close down the subtalar joint. And if it doesn't close down, you can just run your saw blade through to take out any asperities and just allow it to close. Because you need to sort of disconnect the talonavicular joint and the Chopard joints from the subtalar joint to correct these, because the shape is abnormal. And often that means taking out the anterior facet, taking out the inferior aspect of the talus, and even a bit of the calcaneo-cuboid navicular complex. And a saw is really good to do that. And then I finish up the forefoot. For the hallux, that's usually an IP joint fusion, a Jones in a younger patient, but often the adults are a bit stiff and a Jones doesn't do much. And lesser toes, I often do FDL tenotomies and PIP joint fusions only if it's a young patient with skin. Otherwise, I do that. So we've done all of that. Now we finally need to get to fix and tension the tendon transfers. Which tendon do you transfer? Well, the stronger one. And in practice, that's often the tibialis posterior, although you can do a peroneus longus to brevis transfer. Peroneus longus brevis to transfer is useful when dorsiflexion is preserved and you just want to get a bit of eversion because it takes away a pronator and adds an everter. I often do this through the calcaneal osteotomy. Just lift the extended lateral approach flap a bit higher and the tendons are right there. But you can do it infra or supramalleolar. But basically the idea is you pull the brevis up, you put the foot in eversion, you pull the longus down and tie them together, which defunctions the bit of longus at the bottom. The tip post transfer is a workhorse. You pass it through the intraosseous membrane. You can go circumtibial, but intraosseous membrane has more power in various studies. It's useful when dorsiflexion is lost. You can insert it into bone or tendon. How do I start? I take a small incision. I take the tendon out there. If you want to go to bone, you need a little bit of a longer incision, or you're starting out and don't do lots of these, then you want to make a bigger incision. That's absolutely fine. Size of the incision doesn't matter. I release the spring ligament as mentioned before, and then I take the tendon out higher up behind the tibia. Again, like Heath, I often do a split, and then I pass it through the intraosseous membrane. I didn't have a video of that like Heath does, but his video is fantastic. Options for insertion, you can insert it into bone or tendon. If you're inserting it into tendon, you can do a single tendon, which I rarely do because I think that's often not as balanced as multiple tendons. If you're putting it into multiple tendons, you can either split it or take one tendon and weave it through multiple. And I usually split it unless the tendon looks a bit weedy, in which case I'll do a single tendon weave. How do you decide? Well, it depends on what you want. If you want more dorsiflexion, go to the intermediate cuneiform. If you want more eversion, go to the cuboid or perineals. If you want a bit of both, which is usual, go to the lateral cuneiform or tibant and peroneus brevis, which is what I often do. You can go under or over the retinaculum. It doesn't really matter. If you want more forefoot control, then you can go to EDL and tertius. Just think about what your tendon is controlling. If you look at this foot, it looks great, doesn't it? But the reality, this is over dorsiflexed at the ankle. And actually, when you have the ankle at neutral, you find that the deformity is at the midfoot. But you can use your tendon transfer to control this if you want to over dorsiflex the ankle. It's just that it's got to be a tendon which spans those joints. So this tendon transfer has got to be to EDL or tertius, or to the cuneiforms to control the equinus, if that's what you want to do. How do you fix it? You can use all sorts of techniques, suture anchors, staples, etc. But biotin adhesive screws are the best for bone. If you're putting it to tendon side to side with some one vicryl is fine, or you can pulver tuft it. Doing through the EDL, you can weave it through and create a pulver tuft through the strands of the EDL. So just winding up now, what does this all mean for patients? Well, if you've had a flexible correction, it's 6 weeks in a cast and 6 weeks in a boot. If you've had a fusion, it's 3 months in a cast and non-weight bearing for the first 4 to 6 weeks. It takes them about a year to adapt and rehabilitate, and they need to be aware of that. They often still need orthotics. It doesn't give them a normal foot, but it's still a lot better with a stable foot, slightly improved balance, and they get into a shoe. But there are complications. In our series, up to 40% of people have some wound or the other which doesn't heal within 2 weeks. And wounds can break down, tendons do pull out, you can have non-unions, malunions, under or overcorrection. Sometimes the metalwork needs to come out, and you always need to warn them that it can reoccur or progress over time. That is slightly less common with fusions. And what are the results? So Dishan Singh published this, 25 patients using a variety of procedures, bespoke but according to similar algorithms, and noted that by 1 year and maintained for 4 to 5 years, the foot shape improved, pain improved, velocities improved, quality of life improved. But interestingly, it didn't help the falls and overall balance because that seemed to be multifactorial. So my final thoughts, history and examination, as Heath mentioned, is key to treating patients. Every patient is different and needs a bespoke treatment. But hopefully I've laid out, and Heath's laid out, a systematic approach that you can follow. But I think it's most important to understand the basic principles, because that will help you understand when to deviate from all that we've said. Thank you very much.
Thank you, Karan. That was excellent. You have laid out really nice, principles out there, or try to simplify this complicated, neurological problem. So what I'll do is I'm going to kickstart the discussion, and I'm going to use 2 questions from audience, and I've got a few questions of my own. So first of all, there is a question from Benedict, who is asked, and both of you can chip in, if you do a tibialis posterior transfer, is it not important to stabilize the Chopard joint as well?
Should I go?
Yeah, yes, you go first.
Yeah, I mean, it's a great question, and it's a question I've asked, and it's a question that often gets asked by trainees or by people who, you would think we spend so long, anyone who has a tib post dysfunction ends up with a planar valgus foot. So how can we just harvest tib post? The honest answer is it doesn't seem to matter. I can't think I don't think I've hardly ever seen somebody develop a flat foot from harvesting tib post. Do you need to stabilize the tendon and navicular joint? I don't think you do. These feet are already quite stiff, and they're cavus anyway. And so I think the spring ligament and the plantar capsule and the tendon and navicular joint itself is so generally quite stiff and stable if you're doing this, a tib post transfer in isolation. So I don't stabilize the Chopard joints or the medial column. And it doesn't seem to be a problem. I can't think I've had a foot that's collapsed after I've just taken tib post. And I think it's for those reasons.
I'd agree with that. I think the science behind it is, there was a paper in 2022 which looked at weight bearing CT and analyzed the morphology of the feet. I wish we did that paper, but we didn't. What it actually shows is that the bony structure is abnormal, and you have a hypoplastic infromedial talar head. And you have a hyperplastic bits of the navicular, hyperplastic bits of the calcaneus. And the Bowler angle and angle of Gissane are all different in a Cavovarus foot. The angle of the subtalar joint, the angle of the medial facet to the posterior facet are all so different that the bony configuration prevents you from getting a flat foot. And you never, ever, ever will get a flat foot, no matter how hard you try. The one exception that's only happened to me once is I had a patient who was CMT type 2. And remember, the CMT type 2 patients don't present in their adolescence. They present in their 20s. And therefore, she had a milder version. And although she presented with profound weakness, it was later in life after her bones had already formed. And so in that situation, I did actually put her tib post into cuboid and say, wow, that's pulled her over. But she's the only patient that's ever happened. And on table, I recognized it, took it out and put it more medial, and she's been fine. So in the CMT type 2s, you could possibly have it, but most CMT type 1As, CMT Xs, and CMT type 4s, of which there are only about 16 in the world or something, they will not get a Cavovarus foot for those reasons. Sorry, not get a flat foot for those reasons.
Thank you. So whilst we are on the subject of tibialis posterior transfer, can I ask you, both Heath and Karan, do you always do a split transfer, or do you vary? And if you do a single versus split transfer, how do you decide and when do you do it?
Do you want to go first with that one?
I think it depends on the phase of the moon. Depends on what happened to my last patient. It is art. I have to say, I sometimes don't decide till on table, and to be completely honest, the reality is that I don't think there is a perfect tendon transfer. And sometimes you see something which you think is not perfect and the patient is delighted. Sometimes you do a tendon transfer which you think is perfect and the patient hates it. I prefer going tendon to tendon because I think tendon to bone have an early failure rate pull out. I have to make bigger incisions and I always struggle to get it in. Sometimes the bone is soft and I think the cuboid is going to explode when I drill the hole. If the tendon is big enough, which it is mostly, I will do a split transfer because I think that's more balanced and I think I can attach it to the inside and outside of the foot and it almost becomes like a bridle. And the reason is if I do a single tendon transfer, then I have to put it into somewhere in the middle of the foot, which ends up being EDL. And if you go into EDL, I find sometimes that makes the toes claw up more. I went through a phase where I hated that, so I actually started putting it into EDL, attaching EDL off the toes and reinserting EDL like a Jones procedure into the lesser metatarsal heads. But it was a total faff. It did work very well, but then I thought the split transfer worked better. So my default nowadays is a split for those reasons. You'll have different experiences.
Yeah,
I'm sure.
I mean, I think a similar answer. I agree with you about the bone fixation, and I've broken a navicular and a cuneiform, and I think if the bone's soft, older, postmenopausal women, I think trying to use an interference screw, because often you want to put it in really tight, and you're really asking a lot of the the fixation to hold. So tendon to tendon is a better fixation. I think if I'm just doing it for foot drop in isolation, then I tend to just do a singles, into the top of the midfoot somewhere. But for a neurological foot where I'm trying to get balance, then I'll split it. That's sort of how I think about it, which I think is similar to what you said.
Yeah. No, I agree. Thank you very much for that clarification. The other two questions which I had put in, Heath, both of you have covered Achilles tendon lengthening in detail. And Heath, looking at your talk, and I agree, I like it. I like to release Achilles tendon more often than not. But I do majority of mine in neurological by the Hooks procedure. Do you do the same, or do you do open procedure for Achilles tendon lengthening?
Yeah, so I really liked Karen's way of trying to be slightly more scientific about it. So I just have two types of Achilles tightness, which is the Heath Taylor type 1, where you can just do three little cuts and kind of push until it goes with a pop. And then the Heath Taylor type 2, where it's just so tight that you just think it needs more. And then I do an open, I do a coronal split. So I get a 10 blade and I split it coronally so that they slide over each other. I just find it's a less bulky repair and it doesn't seem to press on the wound as much. So I think I like Karen's more scientific way of saying what I've said, but I think if you need a bit of correction, 3 little cuts is fine. But if it's a really big, tight, if the heel's off the floor completely, and then I'll do it open and I do a coronal split, coronal Z basically.
Wonderful. Whilst you're there, Heath, you did mention about plantar fascia release as well in one of your patients. And we in UK do not do a lot of plantar fascia release. And I just want to have your take with your experience. What do you think?
Yeah, we don't. You're absolutely right. And whenever we have a sort of local complex foot clinic, and you go off to, we all go to sort of case conferences and people show cases, and I've no science to it. I went to watch a chap called Wolfram Wentz in Heidelberg do a lot of severe cavus deformity, and he was doing quite a lot of plantar fascia releases, and so I started doing it. And again, I've rarely regretted doing it. I haven't given anybody a flat foot. I think it just allows that arch to come down nicely. So I will often just decide on table if I just think it feels, when you push the first ray up and it just sometimes feels so tight, I'll just make a small incision and release it if I think it feels tight. Again, I'm afraid it's the Heath Taylor type 1 and the type 2. I can't give you any more than that. But I do it more than I think some people do. It's a bit out of fashion in the UK. Yeah.
Thanks, Heath. What about Karan's type 1 and Karan's type 2?
What, Achilles?
No, for plantar fascia.
So I think it's as I said. I think when you release the spring ligament and the talonavicular joint comes around, it often, by just virtue of being in the right plane, all of a sudden it releases. And remember, I take a wedge with a shift, and what I do is I detension the plantar fascia through my osteotomy. So what I didn't mention is my calcaneal osteotomy. I don't just go flat across. I do a shortening osteotomy. So when you're looking at it, if you're bringing the heel towards you, if you tilt your hand so that your hand goes more distally, and you do the osteotomy, then what you do is you bring the insertion of the plantar fascia inwards a little bit as well, and you detension the plantar fascia that way a little bit. And I think the ones which are really tight, like Heath said, I tend to end up doing wedge tarsectomies on them anyway, and then I base my flap on the fulcrum, not on the bone, but on the plantar fascia, so I detention it. I think I've done 1 or 2 plantar fascia releases, not very many.
Okay, fair enough. No, that's absolutely. Heath, you did. You did touch base upon subtalar joint fusion, and I agree with you. It's difficult with calcaneal shift. So I've got to ask 2 questions. First of all, I've always found that the medial displacement is easier in calcaneal osteotomy as compared to lateral displacement. Are there any tips as to how you get more correction resecting more bone using burr or obviously releasing Achilles tendons, anything like that? And second question was regarding your subtalar joint fusion. If you're doing subtalar joint fusion for a varus deformity and you're releasing the medial structures, do you use a medial approach to do subtalar joint fusion, or you do the lateral approach?
Okay, so question one is tips for doing a calcaneal osteotomy. So I almost never do just a wedge, because I think I really liked the Karan's animation on the banana, I'd sort of heard that and I'd seen that paper. I think that demonstrated it really nicely. But I do a wedge and a shift as well. So I do a wedge and I go put the laminar spreader in. I go all the way through the medial side, being careful, obviously, and then I release all the medial soft tissues. And so I close the wedge and then I slide the heel fragment as well. And I'll often slide it by a centimeter or so. So you've got the wedge and the slide. So it's a sort of modified Dwyer. I've made that name up. I don't even know if it's called that, but you know what I mean. And I think that gives more correction. I think just taking a wedge, I've done that a few times, and you think, I've taken a big wedge, 10, 12 millimeters, and they come to clinic and they stand up and it's still in a bit of varus, and just think, I'm sure I had this better than this. And so I now will always slide it as well. So that's, I don't know, and get it really released, and I really release those medial soft tissues. Your second question was regarding the approach. I do almost all of my subtalar fusions from the lateral side, certainly for hindfoot varus, because that's the sort of friendly side for the wound anyway for this deformity. And I do it all from the lateral side, and I'm just, with experience, you get used to getting the laminar spreader in, and I get right through to the medial side. I see the medial soft tissues, and you see FHL running in the back corner, and I just release it all and make sure, and I'll take bone away if necessary, to allow that correction to come. I agree with Karan. It's interesting. I think the more severe the deformity, whatever you're doing, taking bone away is your friend. So shortening and, just don't be scared to take bone away. It's not like doing an in situ subtalar fusion for a bit of arthritis. So take bone, and it just relaxes everything.
Thank you, Heath. Karan?
I just echo everything he said. My tip, as I said, for the calcaneal osteotomy, laminar spreader, take a curved osteotome, poke it around the side, and just try and lift the soft tissues off the calcaneus on the medial side. And you got to sort of hold it like that and take it down and be really gentle and sneak it around and do it. But if you do that, then it allows you to get a better shift. If you skip that step, then I think you struggle and you fight. The other thing is, as a hook, if you really can't do it, a hook really helps. But, I usually do the hook before the calcaneal osteotomy, so it's not a problem.
Yeah, me too. Yeah, no, thank you. So few more questions have appeared from our audience. First one, can we do a staged correction, or we have to do all the corrections in one setting, hindfoot, forefoot, midfoot?
I'll go first. So I don't usually do toes when I'm doing a cavus foot correction. I think, Karan, I heard you said that as well, and I agree. I think for a few reasons. One, I can't stand doing toes. Another reason is I worry about infection. So you're going to put wires in toes, or however you fix your toes, and I worry about that if you've just done a big hindfoot. And also, I think you don't know what's going to happen to the toes, because there's often a bit of flexibility. And I've had quite a few cavus foot corrections where they've got quite significant claw toes. And if you get the hindfoot and the midfoot right and leave it for 6 to 12 months, they don't complain about the toes. And actually, I think the toes sometimes just kind of settle down a bit and they relax down a bit. And so I don't usually do the toes, which that fits with the sort of how long does it take question. So do I do it all in one go? Yeah, I do it all in one go. I don't do the hindfoot and then come back and do something else. It's just about doing it regularly and being efficient, and make sure the procedure keeps advancing. And, if you've got a tendon transfer and a fusion to do, and you're doing the fusion and then you ask for the screws, and I had this morning. I was doing a subtalar fusion and an FDL transfer, and I would do the subtalar fusion, and for whatever reason, they hadn't opened all of the drills that go for the screws that go across the subtalar joint. So you can either sit there for 10 minutes and wait for the screws to come. Well, I just got on and started harvesting FDL. By the time the screws arrived, I'd done most of the tendon transfer. So it's just about being efficient and using your time efficiently and progressing through the procedure. So I aim to do it all in one go. I don't know, Karen, how long do you let your tourniquet stay up for? When do you get nervous?
I don't mind really. I mean, I usually let it down between 2 and 2.5. But to be honest,
2.5.
I never get that far with the cavus foot anymore. Anyway, I echo what Heath said. Exactly the same thing. I think the toes swell more. Don't like the wire sticking out. I think for the want of the toes, it sacrifices the blood. It confuses the blood supply to the rest of the foot, which may compromise another wound. I tell all my patients, you got 4 operations with me. You got your big operation on your right, your big operation on your left, about 9 months to a year later, and then you'll come back a year later after that to have one foot then and then the other. So we'll know each other for 3 years or so. And it takes a lot of time in the beginning, especially if you're not used to it and you have to think. And when I started, I think it was, it would take me 2.5 hours, and I'd be letting the tourniquet down and thinking, oh my God, I'm running out of time. And now it takes me an hour and 15 minutes or something to do a cavus foot. It's just as you understand the flow and as you do lots of them, it becomes easier.
Thank you. Yeah, no, I mean, I have I was reviewing one of my patients who had a cavus foot with arthritis, and I did a hindfoot nail, first metatarsal osteotomy, Achilles tendon lengthening, and they had a lot of deformities of their toes, but I was reviewing their X-rays, and the toe deformities when I was reviewing flattened, so look pretty good. So yes, I agree that you don't have to do the toes.
Is that because you kept the plantar fascia intact, by any chance?
Yes, I did. Is that your point? Thank you. So the next question is about the testing, neurology, genetics. And then one question I'm going to ask you both, what's your experience of idiopathic Cavovarus deformity? Is that
first? Or So genetics, we're lucky. We are partnered with Queen Square. So we know a neurologist. We often get a lot of referrals from them, but equally, if I have someone without a diagnosis, I will often send them for a diagnosis because they often need a lot of support in other things, particularly if hands are affected, etc. And they often want to know what the risks are to the rest of the family, particularly if they're young. Even if I suspect idiopathic cavus, I will often send them for a review because, I mean, at the end of the day, what do I know? I'm an orthopedic surgeon. The idiopathic cavus is different. Alessio Bernasconi, when he was with us, who's now a consultant in Naples, did some work on this, comparing CMT versus idiopathic. And there are differences. For one, they don't have as much rotation. They don't have the same, so they have deformity, but it's mostly in the sagittal plane. They don't really have as much coronal plane deformity. And he didn't quite manage to find this, but I think that's because of the methods they use. But my personal experience is that if I see someone with a very high calcaneal pitch, I think they're much more likely to be idiopathic cavus than CMT. Most of my CMT patients don't have a high calcaneal pitch, but most of my idiopathic cavus do have a higher calcaneal pitch, and they actually have more pronounced cavus, which is actually harder to treat. So it's just about, again, it's pattern recognition, but it's about recognizing the differences in the pathology that you're treating and treating the right thing for that patient. The other big thing is I'm less likely to need tendon transfers in my idiopathic cavus because they don't have a foot drop and they don't have an unbalanced foot this way. They just need little plane correction to an extent and calcaneal osteotomy. So bear that in mind, really.
Thank you. Heath, do you want to add anything?
No, I agree completely. I think that's exactly right. I agree about the idiopathic ones don't have weakness, so it's just getting they usually just come with either callosities or loading on the lateral border of the foot or peroneal tendinopathy, and it's just a case of, I agree, a sort of selection of osteotomies and a bit of peroneal tendon surgery often is what they want.
Wonderful. One question which I think was very interesting and was directed, and that's the last question I'm going to take, was from my pediatric orthopedic colleague at Leicester, Anna Peake. So this question was directed to you, Karan, and she complimented you on your traffic light analogy. And she has asked that, is there a role in adolescence to do a tendon transfer to prevent progression? So, for example, if somebody is asymptomatic and they have a correctable or minimum deformity, is there a role of doing tendon transfer to prevent the progression?
Yeah, that's a question, isn't it? I mean, that is the question. So let me put it to you this way: if someone is presenting to you as an adolescent, it's probably because they've got severe deformity, right? So you're unlikely to see a mild deformity presenting to you at adolescence, and if it's not correctable, then absolutely I would. I mean, some of the hardest cases are 17, 18-year-olds who've just had really onset. Their grandparents have had it, and it, whatever anticipation or whatever, their phenotype is quite severe. It's actually sometimes harder to convince them that they need it. And the traffic light system is one way, but the other thing I do, which I picked up from Nick Geary, is I get them to stand on a paper. And I haven't shown this slide. You've seen the slide before, Maneesh, but I haven't shown this slide in this talk because of time. I get them to stand on a paper and I trace around their foot. And then I put a mark on where their heel is, a mark where their big toe is, a mark where their fifth toe is. And then I draw the marks where the malleoli are, and in between the malleoli is the center of their weight-bearing axis. And you can draw this triangle between the tripod of their foot and say, look, if your weight-bearing axis misses that triangle of tripod, you're just always going to be unstable, and they definitely need something. I try and wait until they're skeletally mature because that's my practice, and I normally don't see that many children. But I wouldn't. If you can see someone is progressing and they're not controlled by insoles, and a lot of adolescents will not wear their insoles, I absolutely think there's a role for that. I've never done a calcaneal osteotomy myself in someone who's skeletally immature, but I suppose it's done. And if they're presenting, they're more likely to present when they're 15 rather than when they're 12. So they'll probably have finished their growth anyway in their heel. So I wouldn't really worry if they are actually progressing. I don't know what you guys, Heath and Maneesh, think.
No, I agree. I think there's no, when young people heal well, the risk of complications is low, the recovery is good. And I think sometimes it's often fitting it into their life as well. So, GCSEs, A-levels, university, all this sort of thing. There's the timing of this thing, because, we all know the recovery takes ages. And so it's fitting it into when they've got a gap in their life to have something pretty major done. And it's often bilateral, 4 to 6 months apart. But I think I don't do young. I'd say my practice is all kids, sort of late teens onwards. I don't do younger kids, but 17, 18-year-old, if they've obviously got a progressive deformity with a plantar flex first ray, I think to balance them and do a longest to brevis transfer and once they're skeletally mature, I have no problem doing that. And I agree they don't come asymptomatic. I don't think I've ever seen that. They always come. They've got something.
Thank you both so much. I think it's time now. We have gone past 9, and it has been a very, very educational evening with a wealth of experience and practical tips about this difficult topic, and I'm sure all of us would have learned something today. Thank you everyone for joining us. The next master techniques would be sometime in October, either the first or second weeks. And if there's any burning topic you would like to be presented, then please let us know. I'll be more than happy to facilitate that. So thank you very much. Hope you all have a good evening. And yeah.
Can I add to that, Maneesh? They can let us know on Medall. If you're following us on Medall, on the Medall page, there's a threads comment section, which you can leave comments there, which is easy way to get it to us as well.
Excellent. So you heard that. You can just let us know. And obviously I'm sure you'll be filling your feedback and you'll be receiving the certificates. So thanks once again for joining us on the BOFAS Master Techniques. Have a good evening.
Thank you all.